let me go through my top 10 tests for cardiovascular screening and health. If you guys are new here, I am Dr. Lily Johnston. I am a board-certified vascular surgeon. I also specialize in cardiometabolic prevention, so hopefully you will never need me as a surgeon. At 345 DF says, you talked about boosting your omega-3 supplementation. Have I considered Vascepa, or icosapent ethyl is the generic name? Do you recommend it for your patients? Why or why not? Icosapent ethyl Vascepa is indicated for elevated triglycerides, and it is EPA only. When we talk about omega-3 fatty acids, we're usually talking about EPA and DHA. If you go back to our ApoE4 video, you will remember maybe that we talked a little bit about the distinction between these two different fatty acids and where they go and what they do. EPA is typically more related to cardiovascular health, reducing vascular inflammation, and certainly lowering triglycerides. DHA is more important for brain health and the membranes that we have in our nervous system. And the DHA can sometimes increase LDL-C a little bit, which is why when they formulated icosapent ethyl, they wanted it as an EPA-only version. Personally, I think there's some benefit to having a mixed EPA-DHA supplement, and I don't have a need to lower my triglycerides. So for me, no, I'm not going to do the icosapent ethyl. I think I can get a safe, well-tested, and validated supplement, and I don't feel compelled to do that. For patients who do have hypertriglyceridemia or elevated triglycerides that are difficult to manage through other means, I will discuss the use of icosapent ethyl for them. But the truth is I have very few patients who are actually on it. So there's where I stand on icosapent ethyl. Not for me right now, but can be used for patients in the right setting. At Malcolm Ackman says, good overview. Unfortunately, I would still give this presentation a failing grade for not showing the units of measure in these tests. I may be assuming my audience is primarily US based and is familiar with the measurements, but I would argue this is an oversight. And a related comment from George, I am surprised normal rates are not listed next to the findings. Why? Okay, this is because I grabbed these out of the medical record where my labs are hosted, and they just don't have the normal range next to it, right? These are clinician-facing labs, and they assume that we have some basic understanding of what these are. When I hover over them in my medical record, I can see what the range is. But the other point, and this is not about units, and that's a fair criticism, so I apologize for that. But the point about optimal versus normal range, here is a good one. I don't like necessarily to be distracted by what the lab says is normal when I am frequently using a tighter range to describe what I think is optimal. But it can be helpful for viewers to have a sense, at least, for what the lab says is normal. And next time I go through labs with you guys, I will endeavor to make that available visibly for you so you can see what the lab says is normal. Tennessee Bound for homocysteine is a methylated B or B complex. Thanks and awesome videos. Thanks, Tennessee. So for elevated homocysteine, I like a methylated B supplement. Usually that is actually a methylated B complex. It will include like methylhydrotetrafolate or a folate methylated version, as well as like methylcobalamin or like a methylated B12 version. There may also be TMG in there, trimethylglycine, some other methylated Bs. So you'll usually get a bunch of different Bs in that methylated B complex, but when you turn your bottle around, you want to look down that ingredient list and make sure that that methyl thing is listed as part of those different B supplements that are in your B complex or on your label. Most high quality brands will do this now, but please double check. If it's not specifically marketed as a methylated B complex, just turn around that bottle, look down the ingredients list and see what's in there and if it has the word methyl in it somewhere. At A. Smith, can I share which lab test company I used? Was it Function Health? No, I don't particularly use Function. I just order labs for my patients through my hospital. So Scripps has its own lab, but I also have many patients who don't see me in person, and we will use Quest or LabCorp. There are some links that were in the original video for ways to go get your own labs done. You can do that through Own Your Labs. You can do that through Ulta Labs. Quest and LabCorp actually have their own that you can order as well. The other two I mentioned first are usually less expensive, but you don't need a whole big fancy panel. You can get these a la carte or do that yourself. Your doctor can order these for you a la carte through your regular physician's office, your hospital system, whatever you have. So I just did these through Scripps, and that's what I used. At Peter Bedford says, hs-CRP can be very different at different times of day, not reliable, better to use GlycA. This is a really interesting thing and speaks to the need for us to have a whole video on inflammation and maybe just one on how to measure it. So high sensitivity C-reactive protein was the inflammation measure that I discussed. Now, the guidelines would actually suggest that you should measure this twice, 2 weeks apart, because there is some variability in the hs-CRP. Truthfully, as I see it measured in my patients, I see it varying slightly. It's maybe 30 to 40%. It's not enormous. Again, if you've been sick, don't get your inflammation checked. If you've just been injured or have some other major source that you know is inflammatory, probably don't measure your inflammation marker during that acute phase period. But if you think you're in your general baseline state of health, a couple of those values 2 weeks apart should be pretty good. Now, is GlycA better? What is GlycA? There's a whole rabbit hole here. GlycA is actually a set of different compounds with glycated markers on them that is tested in NMR, similar to the way we measure lipid particles. I know, super nerdy. We'll get into it in another video. We will do the whole inflammation deep dive because there are some vascular specific markers of inflammation that I like, LPPLA2. This is its whole own thing, but thank you, Peter, for bringing the fact to our attention that hs-CRP is not a perfect measure. It's pretty good. Frankly, it's what is used in the cardiology space to talk about inflammation as the risk factor. Most of the trials use hs-CRP. The impact of some of the lipid-lowering therapies, like the statins, is on hs-CRP in particular. It may have less of an impact on GlycA or the series of compounds that is encompassed under GlycA. So let's get into it in a whole separate video. It's a great topic. Thank you for bringing it up. Okay. At J-Persification, this was very interesting to me in evaluating my own labs. I would love to see a top 10 labs for cardiovascular health and how to interpret. All right, I'm not going to go through how to interpret them, but I think this is a fun test. So let me go through my top 10 tests for cardiovascular screening and health. Number 10, hemoglobin A1C, measure of the average blood sugar over about the last 3 months, depending on your red blood cell lifespan. Number 9, I'm going to say HOMO-IR, which is the homeostatic model for insulin resistance. This means I actually get a twofer because I have to have a fasting glucose and a fasting insulin to measure HOMO-IR. So I get 2 for 1 in that one. That again is helping us understand how the body is processing its excess energy and whether we have signs going on about insulin resistance and whether the pancreas is working too hard to manage the energy that we're bringing in. Number 8 is a fasted standard lipid panel, mostly so that I can have the fasting triglycerides and the HDL for a triglyceride to HDL ratio, which again, we're talking about 2 out of the 5 components for the metabolic syndrome. If we have the fasting glucose from the HOMO-IR, that gives us 3 out of the 5. I think you get where I'm going with this about the importance of your metabolic health and your body's ability to process excess energy and its role and importance in the formation and progression of plaque. All right, number 7 is ApoB, right? Of course, I will have the LDL-C from the fasting lipid panel in number 8, but ApoB, as you will maybe have noticed from that last video, is a better measure overall. It's becoming more and more common and standard, and especially if there is what we call discordance or a discrepancy between your LDL cholesterol and your ApoB, that is informative. That actually gives us even more information about your risk profile and those lipoproteins that are circling around in your bloodstream, carrying your cholesterol, and helping us understand to what extent that might be contributing to the progression or formation of plaque. All right, number 6 is high sensitivity C-reactive protein. We just talked about this. Inflammation is important. It is linked specifically to the risk for cardiac events. And we know that if we lower it, we can actually lower the risk of cardiac events. Now, there's some interesting data about whether that improves all-cause mortality. I think that has to do with whether we're suppressing the native inflammatory response in the body or whether we are actually understanding why the body is inflamed. Is it visceral adiposity? Is it periodontal disease? Is it some toxic exposures? What's going on that's raising inflammation? And if we can get that under control, I actually think that probably will result in improved overall health and likely improved total all-cause mortality, but a little bit of a data-free zone there. A runner-up for this would be LPPLA2, like honorable mention for vascular specific inflammation. Truthfully, that's more specific, and I think most people would benefit from getting hs-CRP as the starting place. And if you have more questions about LPPLA2, put them down in the comments below. Number 5, Lp(a), lipoprotein(a). This is something you should get checked once in a lifetime. We don't need to keep checking it over and over again, except for a couple of specific cases, which I mentioned in the LPA video series. If you have not watched those, please go check that out. Number 4, homocysteine. We have also talked about this as the intermediate in the methylation pathway. It is associated with increased risk for heart attack and stroke, and it is modifiable, typically with dietary and some supplementation changes. All right, number 3, microalbumin to creatinine ratio. This is a urine-based test, and we talked about it in the last video. It detects whether the kidneys are spilling spilling protein into the urine inappropriately. We're supposed to be keeping all the protein in the body. It's good for us. We are not supposed to be letting it spill out into the urine. When that happens, it means there has been stress on the kidney, probably from elevated blood pressure or diabetes, insulin resistance, and metabolic syndrome. That is a canary in a coal mine. And the typical cutoff range in a lab is 30, but I start paying attention at 10 or even less, depending on whether you're a man or a woman. And again, that alerts me to the idea that perhaps there's a blood pressure issue we're not detecting in clinic, or even an insulin resistance issue that hasn't been brought to our attention yet. So microalbumin to creatinine ratio is number 3. Number 2, omega-3 index. There is absolutely a relationship between a low omega-3 index and risk for major adverse cardiac events. As your omega-3 index goes up, that risk goes down. I think this is a good one to look at. And number 1 on my list of top 10 things for cardiovascular health that you should get checked, and it's not a lab, it's imaging. You need to know whether you have plaque or not, because all the labs in the world are still driving at population averages and overall risk, but they don't answer the question whether you have it or you don't. I have seen people with very good labs who have plaque and didn't know it, and I have seen people with god-awful, or at least very abnormal labs who don't have plaque. Now, we can argue about whether then we should treat those numbers because perhaps there's a risk for developing plaque in the future. That's another conversation for another day. At the end of the day right now, what we need to know is, do you have the disease or don't you? And it really impacts how aggressive we are going to be with all of the other things we just talked about, like your inflammation, your insulin resistance, your toxic exposures, your sleep, stress, and recovery. All of these things will be impacted by the presence of plaque. So imaging, coronary calcium score if you must, CCTA or CIMT if you are able to get them, so that we can evaluate the soft plaque burden versus the calcified plaque burden. All right, that's your top 10 list. I hope you enjoyed that. Leave me questions down in the comments below. Until next time, take really good care.